Greetings, everyone. This is Chad, and this case presentation comes from a Cath Lab rotation I did back on April 22nd, 2014. Patient was a 56-year-old Caucasian female. She was 5'7" and weighed about 263 pounds. And she initially presented to the ED here at Loma Linda with the chief complaint of chest pain at dialysis. As far as her family history goes, her mother had an MI in her 50s, and her father also had an MI at age 47. As far as substance use goes, the patient was a former smoker, but she quit back in 1977 at about age 20. And she also used to be a heavy drinker until she quit in 2000. Patient has no known drug allergies. And as far as medical history goes, she has a history of hypertension, history of type 2 diabetes, and she has end-stage renal disease for which she's on dialysis every Monday, Wednesday, and Friday. And the chart didn't say how long she's had these diseases, but they did precede her current complaints. Additionally, the patient is rather obese. Her BMI was 41.2, which would put her in the class 3 ranking or high risk category. Specifically, with her cardiac history, the patient has a known history of coronary artery disease. She has had a triple bypass in the past and a recent stent placed at her first diagonal artery. I wasn't able to get the dates on those, but she did have an end-STEMI or non-ST segment elevation MI back on the 27th of August of 2013. And when she had the heart attack last August, they sent her to Cath Lab, and the Cath revealed the following results. She had a proximal first diagonal, 100% in stent restenosis. So she already had a stent here in her proximal first diagonal, and that was 100% occluded. Her right coronary artery over here showed diffuse severe irregularities and calcification in this area. Her distal right coronary showed an 80% stenosis, and her mid-posterior descending artery, which would be the one around the backside right here, showed 100% stenosis. Additionally, there was an occluded coronary graft stump noted with indeterminate pathways. At the time, the patient was recommended for medical management, and she was started on aspirin, Plavix, metoprolol, pravastatin, and Ranexa. So let's look at these medications. Aspirin will act as an antiplatelet, and it does this by blocking the production of prostaglandins and thromboxanes by the inactivation of the enzyme cyclooxygenase, or COX. And aspirin inactivates COX through acetylation, meaning it'll attach an acetyl group to the enzyme, and it does this specifically to the serine residue on the active site of the COX enzyme itself. Additionally, the patient was started on Plavix, and this is an antiplatelet as well. It acts by irreversibly inhibiting a specific adenosine diphosphate, or ADP receptor, on the platelet cell. And the receptor is on the cell membrane. It is the P2Y12 receptor. This specific receptor is involved in platelet activation and eventual cross-linking with fibrin. And by blocking this receptor, Plavix can block platelet activation and fibrin binding. And one thing to know about Plavix is it's what's known as a prodrug, which means it's administered in its inactive form and becomes activated once metabolized. And it's going to do this with the enzyme cytochrome P42C19. It's this specific enzyme found mainly in the liver, and that's what will activate Plavix. Additionally, the patient was started on metoprolol. This is a beta blocker, specifically a beta-1 selective blocker. And the beta-1 receptors are located primarily in the heart. There's some in the kidneys. And so this drug will block the sympathetic stimulation of this tissue. And beta blockers are often prescribed post-MI as a cardioprotective measure. They act to reduce the workload of the heart by reducing heart rate, the force of contraction, and the electrical conduction velocity through the AV node. Our patient was also started on pravastatin or Pravachol. As the name tells you, it's a statin, and statins are competitive inhibitors of the enzyme HMG-CoA reductase, which is a rate-controlling factor in cholesterol biosynthesis. This will thus lower LDL. And lowering LDL reduces the lipid concentration of the atherosclerotic lesion. This will decrease the likelihood of thrombus formation and vascular occlusion. In addition, statins also have other cardioprotective effects as well. For one, they improve endothelial function as evidenced by enhanced synthesis of NO or nitric oxide. They also inhibit monocyte penetration into the arterial wall, which will reduce macrophage secretion of the metalloproteinases. Those are the enzymes that degrade and weaken the fibrous cap of the atherosclerotic lesion. And finally, statins are believed to be anti-inflammatory as well. And the final medication our patient was prescribed after her heart attack last August was ranolazine or Ranexa. And the exact mechanism is not fully known for this drug, but it's been shown to reduce angina without reducing the heart rate or the blood pressure. And it's thought to do this by inhibiting the late sodium current, which affects sodium-dependent calcium channels and preventing calcium overload. So we know calcium is involved with muscle contraction, smooth muscle contraction in the blood vessels. And so if we prevent that calcium overload, we can maybe prevent some of that vasoconstriction and chest pain. This past October, the patient was also started on Imdur or isosorbide, and this is a nitrate which will cause vasodilation through increasing NO levels. And nitric oxide activates smooth muscle, guanylyl cyclase or GC, to form cyclic GMP. Increased intracellular cyclic GMP will inhibit calcium entry into the cell, decreasing the intracellular calcium concentrations and causing smooth muscle relaxation. So kind of like our previous drug, you decrease the calcium inside the cell, and that will decrease the smooth muscle vasoconstriction. NO also activates the potassium channels, which leads to hyperpolarization and relaxation of the smooth muscle. And finally, NO acting through cyclic GMP can stimulate a cyclic GMP-dependent protein kinase that activates myosin light chain phosphatase, another enzyme. And that enzyme dephosphorylates myosin light chains, which can also lead to relaxation. And more recently, since April 9th of this year, the patient has also been prescribed benazepril, and it's one of the prils, so we know that's an ACE inhibitor. And benazepril will act by inhibiting the conversion of angiotensin 1 to angiotensin 2. And we know that angiotensin 2 has many effects throughout the body involved in raising blood pressure. Angiotensin 2 will increase sympathetic activity. It will increase tubular reabsorption of salt and water, so increase the circulating volume. And angiotensin 2 is also a very potent vasoconstrictor. So we inhibit the production of angiotensin 2. We inhibit all those effects related to increased blood pressure and increased strain on the heart. Okay, so let's consider her history of present illness. At dialysis, the patient developed a sharp stabbing pain in her mid-chest that radiated to her left arm and left side. Her pain persisted despite receiving 325 milligrams of aspirin and 2 sublingual nitroglycerins at her dialysis clinic. The paramedics were called and the patient was transported to the ED here at Loma Linda. In the ED, she received morphine, which she reports was able to bring her pain down to about a 4 out of 10. And additionally, the patient was admitted earlier that same month with a similar complaint. The pain was, it also began at dialysis, was also described as sudden onset sharp and stabbing pain, radiating to left chest, and in this case to the back. On that admission, ACS was ruled out, and the patient was discharged home. So let's consider some of her diagnostic data from this current presentation. The patient's 12 lead showed a normal sinus rhythm with no ST segment elevation or depressions. No other ischemic changes were noted on the 12 lead. The patient had normal heart sounds, no murmurs. But despite her normal 12 lead, the patient did have an elevated troponin T level. It was at 0.15. However, despite this elevated troponin, patient was judged stable. This level was judged stable from her previous admission earlier that month. So here would be a good place for a brief discussion about troponin. Troponin is a regulatory protein in muscle cells. It's found on the actin thin filament. It's composed of 3 subunits: troponin I, troponin C, and troponin T. And this complex is found at regular intervals along the actin filament of the myofibrils. Troponin I inhibits the ATPase activity of actin-myosin interaction. So remember, I for inhibits. Troponin C, the C subunit, is responsible for binding calcium ions that will regulate the contractile process. So you can remember C, calcium. And troponin T links the troponin complex to the actin and tropomyosin molecules. So T, tropomyosin link. And although these subunits are found in both skeletal and cardiac muscle, the cardiac forms of troponin I and troponin C are structurally unique, and highly specific assays for their detection have been developed. Because serum levels are virtually 0 in healthy people, even minor elevations in troponin I or troponin T serve as a very sensitive and specific marker for myocyte damage. In the case of an MI, cardiac troponins begin to rise about 3 to 4 hours after symptom onset, and they will peak somewhere between 18 and 36 hours, and then slowly decline from there over about 2 weeks. So in this case, we were given the troponin T. Normal levels are less than 0.01 nanogram per milliliter. And patients with low level elevations, which are typically less than 0.20. And if they have some diagnostic uncertainty, they should have repeat troponins measured to determine if there is an acute elevation or if this is something more chronic. It should be noted that troponin T in and of itself does not indicate an ischemic mechanism. However, you must consider some other causes such as trauma, heart failure, hypotension, myocarditis, things like that. So what's our impression? Was this an acute coronary syndrome or not? Well, we can't call this a STEMI because there were no ST segment elevations on her 12 lead. So what about an N-STEMI, a non-ST segment elevation? To be an N-STEMI, there should be some ST segment depression and or T-wave inversion on the 12 lead, plus the elevated biomarkers. As we already said, there were no ischemic changes on the 12 lead, but she did have the elevated troponin T. And then finally, unstable angina. This is angina, chest pain at rest, or in a crescendo type pattern. And the ECG with unstable angina can show either ST segment depression and or T-wave inversion, or it can be completely normal. But cardiac biomarkers must be negative to be unstable angina. With our patient, her troponin was elevated, but this was judged to be quote unquote stable from her previous admission. But if you recall, on her previous admission, she was judged at the time not to be experiencing any acute coronary syndrome. So we're left with kind of a mystery. So on this admission, the cardiologist felt that the patient's chest pain was likely due to a chronic anginal pain, felt it unlikely to be any acute coronary syndrome. But due to her significant cardiac history and her continued chest pain despite outpatient medical therapy, the patient was recommended for Cath Lab. So she was sent to the Cath Lab here at Loma Linda for possible obtuse marginal and right coronary percutaneous intervention, or PCI. If you recall, she was already known to have diffuse RCA irregularities and calcification and an 80% stenosis to the distal RCA. And so here's what happened. Her procedure lasted about 2 hours and 10 minutes. Access was made via the right femoral artery. During the procedure, they did an FFR, or fractional flow reserve, to her mid-LAD as well, using adenosine 168 micrograms per kilogram per minute. And fractional flow reserve measures the pressure difference across a coronary artery stenosis. It's done to determine the likelihood that the stenosis will cause ischemia or not. So it's going to look at the pressure behind the stenosis relative to the pressure before the stenosis. And there is no absolute cutoff point for FFR where you definitely need to place a stent or you can say you're definitely safe. Rather, there's this kind of large transitional gray zone area of insecurity. Clinical trials have typically had a cutoff point between 0.75 and 0.80. Higher levels indicate a non-significant stenosis, whereas the lower values indicate significant lesion. There's a much bigger difference between pressure before and after that stenosis. And the result for our patient was 0.79, so right on that border, almost at that 0.80. But the cardiologist on this case felt that that was significant enough and went ahead and placed a stent. So during the procedure, she did receive one stent to that left anterior diagonal, or the left anterior descending, or mid LAD. She also received a stent to her middle and distal RCA here. So a few important points to remember from this case. One, just because there is no ST segment elevation on her 12 lead doesn't mean your patient is not having a heart attack. On her first heart attack, the patient had no ST segment elevations on the 12 lead. And so we can use our 12 lead to rule a patient in for an MI, but we can't always use it to rule patients out. Number two, just because the chest pain is described as a sharp or stabbing doesn't mean that there's not some sort of acute coronary syndrome going on. The patient described her pain as sharp and stabbing, but still was likely cardiac related, and she still did require stent placement. And finally, there's often a lot of gray area in how to manage these patients. Do they need a stent? Could they be managed medically? It's often very hard to say, and it's left up to the discretion of the cardiologist. This patient received stents after a trial of outpatient medical therapy, and so often doctors like to be as conservative as possible. But if you're going to be a cardiologist, you have to be kind of comfortable with working in that gray area. And I hope you enjoyed this case study. I'd like to thank the team here at Loma Linda for letting me participate in this case, and I look forward to watching your case studies as well. Thank you.